Hey, it's Dr. Greg Jones here. I am very excited and honored, and this is like an honor for me to have Dr. Tyna Moore as my guest today on the Optimization Academy YouTube channel podcast. So for those who don't know, Dr. Moore specializes in the application of natural pain solutions and regenerative injection therapy. So that's your PRP, your prolotherapy, all those injections where we're trying to make your body heal itself. She's both a board-certified naturopathic doctor and a chiropractic physician as well. I'm going to say that over. She's both a board-certified naturopathic doctor and a chiropractor. So 2 for 1 there. So she can inject your pain and crack your pain. Although I don't know if you've done an adjustment in a long time. So, and she brings a very unique perspective and expertise to diagnosis and treatment of pain and orthopedic conditions. She practices exclusively in regenerative injection therapies and non-surgical pain management for orthopedic and musculoskeletal conditions. So I've kind of known Dr. Moore since my first year in med school. I remember there was a conference. It was a sports medicine conference for naturopaths up in Portland, Oregon, first trip to Portland. And so I was such a new doc and I was all about sports med, and I still am. And I was like, oh man, this is really cool. And Dr. Moore gets up there talking about prolotherapy and regenerative injections, which to that point I had never heard of. I was like, oh, this is really cool. You mean you can put a needle in my joint, in my knee, inject this solution, I can heal? Sign me up. I want to know more about that. And that was my intro, and that piqued my interest in regenerative medicine and injections. And it's been a fun ride ever since. And so I want to turn it over to you and kind of tag team the bio here. And we're excited to have you today.
Oh, thank you so much. I'm so excited to be here. I was so honored when you asked me. I was like, it was a hard yes. So. Right. Well, I actually am no longer in practice. I closed my practice a couple of years ago because I am exclusively coaching other doctors in business and marketing, particularly online marketing. And then I have a high-end prolotherapy mastermind where I take doctors through a year-long experience of not only how to inject and how, the best parts about it, but also the business and marketing. That's a little bit foobarred right now with the pandemic. Yeah, So we're getting through that. But yeah, I really just have had such a fun time teaching doctors how to be better doctors all in all, and how to be more successful at it. And that's where my heart has been headed. And I still inject when I teach, and I inject my family and friends, but so far as the practice being open, that is a thing of the past. I can't complain though. I did it for a good solid 10 years and I loved it. And I am really enjoying life outside of a clinic right now.
Okay. Yeah. I mean, that's great. That's how I feel on the weekend. It's like, wow, I'm really enjoying life right now.
Like, well, I grew up in medicine. Like I've always been either a patient or part of working inside a clinic. And I realized around 40 that I can't remember the last time I was not in a clinic. So I stepped away. It's been good though.
Awesome. So, and I've been honored enough to hear you speak at a few conferences on prolotherapy and injection therapies and some of the marketing as well. And we're going to talk more about how to find you on Instagram later, and just watching how you operate on social media. Like, oh, that's really, really cool. And just the work, it's a craft and it's a skill that many of us as docs, especially, as again, we know medicine, marketing, business, social media. It's like, good luck. And hopefully you can find your niche and your lane and go with it. And I think you're very good at, not only your own lane, but like being able to look at other docs. It's almost like a diagnosis of your social media and say, hey, this is where you need some Prolo on your, you need some tight net Laxity on your Instagram page there. So that being said, we're going to talk about Prolo for the next few minutes here, and I'm excited about it. So the first thing is, for those who don't know, what is prolotherapy?
So prolotherapy is really a simple concept. It is as much of a technique as it is what's in your syringe. And what I mean by that is the application of consecutive needle pokes causes a proliferative response in the area. So it causes a modulated immune response to get that area to heal up. A lot of our pain is derived from our soft tissues. People think it's coming from the joint or something they see on MRI, but often it's coming from the ligaments and tendons and where they insert onto bone. And then what we're injecting varies, but generally when people talk about prolotherapy, they're most often talking about a hyperosmotic dextrose solution. So it's a sugar water solution. When injected, causes an osmotic effect to your immune system and calls in the vis naturae, if you will. It calls in the troops into the area, it gets the stem cells in there ignited. It kind of turns things on again to give that joint a secondary chance of healing. So it's as much of a injectate as it is the technique of that practitioner holding that syringe.
Okay. Yeah, and when I'm explaining that to patients, very similar, and it's like just imagine. I'm hard, my analogies get all off base. They're looking at me like, "What?" But for this one, I'll say, "Hey, just imagine, your injury is your store, and the store was broken into, and the cops came, and they're like, 'Hey, here's an injury,' and they assessed the situation. And they started taking notes and trying to solve the crime, but then after a few weeks, another crime happened, and they left." And it's just like, hey, this your store is still damaged. And
Yeah.
eventually with the injections, it's like I'm calling the police again.
Yeah.
I'm calling the troop, as you say, the troops in, or I'm trying to set this alarm back off because we're not healed. And
I
that's
love
just the
that.
people feel like, oh, okay, I see where you're going with that. And it's counterintuitive because that dextrose solution is causing inflammation, that immune response. And people are like, wait a minute. They get a little bit worried when you say the big I word, right? Inflammation, because they're thinking that body wide swelling,
Right.
and it's like, no, we're creating it locally in the area as well. So I think that's important when we're talking to people as well.
Yeah, and it's modulated, it's hopefully we can control that to some degree by choosing healthy patients and also by what concentration of dextrose we're using. And dextrose also calms down neurogenic inflammation. A lot of times joints are just honestly pissed off. It's not even that they've got a lot of structural damage or that those enthesis areas where those ligaments and tendons insert are terribly torn up. It's honestly sometimes just that the whole thing is it's pissed off. And
Right. Yeah.
dextrose does a
Yeah.
beautiful job of calming and soothing. So you think of it almost like as a salve. It's a
Mhm.
wonderful healing salve, and we can increase or decrease the intensity of that salve.
Okay, which makes a lot of sense. Good way to look at it as well. So now that we know what prolotherapy is, like who are the best candidates for it? Like, is there a particular injury set or type of injury or type of patient that you would say, hey, this would be really good for you, kind of thing?
Sure. I think that's super important. And I built my whole practice around that concept, and I got a lot of heat for it, but I had a very successful practice.
Yeah.
Anyone who heals well is a good candidate. And if you cut your finger, I always ask that on my intake. If you cut yourself or first of all, how easily is your skin abrased? When I was in poor health and malnourished when I was younger, I used to brush up against things and just get cut. Like I would just have an abrasion, right? My skin was so friable. And secondly, how fast does that heal? If it takes somebody a long time to heal from a normal little cut or abrasion, they're probably not a good candidate. If they're a stellar healer and they're like, oh yeah, I'm good, I get a scab and it falls off in a few days, probably a really good candidate. Prolo really helps everyone. I've never seen somebody not get some relief from it, but so long as how much relief and how long that lasts, that's where we have to do good patient selection. So I'm looking for people who generally eat a good whole foods diet that is nutritionally dense. I'm looking for people who sleep well, who are active, particularly strength training. I think muscle itself has a huge impact on who gets better. Even the people with a lot of muscle who have terrible diets, they still heal better than the people with no muscle. So having some conditioned muscle, skeletal muscle is pretty helpful. And really, I mean, that's it. I want a generally healthy person who just kind of needs some tinkering with their joint. What I don't think it's best for is those who are just severely deconditioned, those who are potentially very inflamed, those living with obesity or diabetes. They will still get some benefit. It won't be potentially as good. But again, it's up to that patient. I'm very clear in the informed consent of that. I tell them they may or may not get great results, and at least that's not on me if it doesn't happen. I know that we at least forewarn them. But after many years, and prior to me being in practice, I worked for Dr. Rick Marinelli for a good 20 years. So I've been in the prolotherapy world since I was 22. It's in my blood, and I have seen everybody get some version of improvement from it.
That's awesome. So I'm going to kind of piggyback on what patients are candidates. And I think you led me right into it, but I'm going to rewind a little bit because something that, I've heard you speak on and a lot of doctors who teach prolotherapy is the concept of ligament laxity.
Mm-hmm.
And so, we'll talk about that. I'll let you kind of explain that a little bit, but the question will be, can someone feel that as a patient? Like, can you feel ligament laxity and know, like, hey, this ligament's loose? Or is it just the fact that a lax ligament will cause that activation of the pain or those mechanoreceptors for pain? And it's like, I feel pain. So let's kind of dive into that a little bit.
Sure. That's a great question. I don't know if people can necessarily feel it, but what they will feel is instability potentially. The thing about ligamentous pain is that it can be sharp shooting, and it can also be dull and naggy. and it can refer to the point where the sacroiliac region and the low back can refer all the way down into the foot, and someone thinks they have a radicular blown disc. You know, they've got like a radicular symptom, meaning your nerve roots being impacted that goes to the toe, when really it's just a referral pattern from a sacrotuberous ligament, say. So it's up to the practitioner to be skilled at knowing the ligaments and knowing their referral patterns and being able to palpate them really well. I think the cardinal rule for good prolotherapy is good palpation. I think that's the cardinal rule for all regenerative injections. Ultrasound is nice, and I know you wanted to talk about that. We can get to it, but having good palpatory skills so far as I can recreate the patient's chief complaint, pain. I want to recreate that pain as much as I can. If I can recreate it and they say, oh yeah, that's it. Maybe it's local and it's also distal, meaning it's also referring. That's the money shot. I know I can stick a needle there, right? And I know my anatomy well enough to know where to avoid with my needle. But a palpation-based regenerative medicine practice, I think, is something we're seeing a huge loss in. That's what I teach in my mastermind, because that is the critical skill set that a doctor needs. Beyond that, we can grow it up into imaging and we can get fancier, right? Mm-hmm. But I see a lot of docs who are great with an ultrasound probe and have zero palpation skills. Can't diagnose well like that, in my opinion.
Oh yeah, it's like, where does it hurt? You know, that's
right.
the biggest thing, you know, like, hey, I see this here, but it's like, I put the needle everywhere, but where it hurts. And like, and you know it too, when you're injecting, because you hit that spot and they're like, oh, that wasn't bad. That wasn't that bad. Then you hit that spot. They're like, oh, sweet baby Jesus, you know?
Yeah. They go, oh, like they do that. Like, you know what I'm talking about? They're like, oh, like that's it. Like one lady said, that is the pain of my ancestors.
They're reaching through the ages to say, this is where that needle needs to go. Like, yes, my child, you're on the path, right?
Yes.
And so kind of, you know, circling back to, you know, now we got our candidate and you know, you've been through their intake, you've done the palpatory thing, you know where you want to go with the needle, you know, at some point, like, hey, we're going to schedule this injection. What's the ideal environment as a whole person you want that patient to be in? And this can cover, you know, diet, supplements, environmental, you know, toxins, hormones, et cetera, et cetera. I know there's no perfect candidate in this, but what's kind of like your baseline that you want to make sure they're ready to go for this?
Sure. I tell my coaching docs to inject everyone who needs it, who's safe, who's not going to get an infection, right? We want to obviously rule out the big. We don't want anyone with cancer. We don't want anyone who's severely diabetic, because they are more prone to infection. We don't want someone who's severely obese. They are more prone to infection. Beyond that, I say inject everyone as you're learning to see who responds, because you'll get to know better. Also based on your skill set, you'll get to know better. But generally speaking, we want someone who's hormonally sound, because it's an anabolic process. Ultimately, we're just creating collagen, right? We're quelling neurogenic inflammation and we're increasing collagen synthesis. And so they need to be able to have the nutrient status to make collagen. They need to have the hormonal status to be in an anabolic state when needed. So we don't want someone who's severely hypothyroid, because metabolically they'll be turned down. We don't want someone who's got severe testosterone deficiency, because they won't be anabolic. We don't want someone who's severely estrogen or progesterone deficient, because they may have more pain or more laxity or more tension. You know, it doesn't have to be perfect, but we're kind of looking for that. We want someone with good gut health, because we know that poor gut health and poor microbiome status will definitely contribute to pain and lack of healing. We want somebody, like I said, I want somebody who's fit, who's sleeping, who is willing to, also people who are not in a victim mentality. I gotta say, a lot of people with chronic pain, me included, I've been there. I lived with chronic pain for a long time. I got myself there. It's very much a mental state. These people did this to me, and therefore. And we can see that with adverse childhood events and past traumas. That's also something to consider, at least, because people with high levels of that will generally, I think I saw a study that said like 80% of people who've experienced early life trauma will develop chronic pain. So we have to be able to differentiate. Are we dealing with that? Are we dealing with a true biomechanical problem? Can we help the biomechanical problem? And in the meantime, get them the help they need to address that. So there's lots of variables, lots of things to think about. It is not as simple as shooting juice in a joint. You know, you gotta, as a naturopathic physician, I think you know better than anyone, we realize like we're treating the whole person. And so maybe we decrease the pain and it buys us some time to get into the other things, or at least get them referred off to the right people to get the other things dealt with, because that pain will come back. And then making sure there's some adequate, I know this isn't, we're not talking post, but I always make sure that they're willing to engage in some kind of rehabilitation process if needed, because if they're not willing to strengthen and condition that joint and get all of, we're doing a therapy that lays down collagen, and collagen lays down haphazard, and we need it to line up linearly. And the only way that happens is through force on that joint in specific directions. And so they need to be willing to go through that process as well.
Yep, and we're going to talk more about that in the post, and I definitely want to make a point about that. We'll do that as well. So one thing that I've noticed is that we tend to get a lot of people that have done other therapies, especially steroid injections. I feel like most of my Prolo patients have been like, hey doc, I had 3 rounds of, a steroid injection and the pain went away, then it came back, and it came back worse once that wore off. And then I get into the whole conversation about masking the pain, and you think you're okay, so you try to get back to normal activity, and that just makes it worse. Now, from a patient, selection standpoint, is there a particular length of time after a steroid injection that you would consider doing prolotherapy?
Sure. 6 to 8 weeks, I would say, at least. And the problem is how many cortisone injections have they had? Because there's something about proprioception in there too. I don't know if you've noticed this, but I've seen with people who've had excessive cortisone, they do not do as well predictively with these therapies as people who have not. So I can tell someone, like, if you walked into my office, I could tell you with fairly good certainty how you would respond based on your overall health and physical conditioning and the state of your injury. I could say you're going to be this much percentage better by this point. And I'm usually pretty spot on because I've had a lot of experience, been at this a long time. With people with cortisone, I say all bets are off. Like, I have no idea. I don't know if you're going to respond. I don't know how long it's going to take for you to respond. I don't know if Prolo is going to be enough. And I also find that I have a much harder time recreating that chief complaint pain. Something about the proprioception and the pain receptors in that region have been altered in such a way, specifically in the back, if we're talking spinal, that I have a very hard time recreating those injuries with the pain with my fingers, because the cortisone has sort of shut it all off in a weird, vague way. Like, they're hypersensitized, but it's all shut down at the same time. It's almost like a scar. You know how scars are weird? They like hurt weirdly, but they're numb. That's kind of what cortisone does to the joint. And cortisone is super catabolic, like cats. Think cats chew up your tissues, right? That's what I say to patients. And there's been a lot of tissue melting that's gone on from that cortisone injection. And if they've had several rounds, we are dealing with an entirely different beast. It's kind of like, I tell patients this, I say, it's kind of like if I were a veterinarian that specialized in dogs and you brought in your cat. Yes, I'm trained in it. Yes, I can help your cat, but cats are not dogs. And cortisone injection patients are more like cats. Like, all bets are off. I hate to say that. And I'm sorry that you're dealing with a lot of them, but that is a tough group.
Oh yeah, they've been my most challenging compared to some of the athletes who come in, who've been trained. They're just trying to get back on the field or the court, and they've tried different things, but you hit that person who hit 4 or 5 rounds of steroid injections, and then you have to have the conversation about, well, you got to pull out the research, and not trying to scare you, but hey, there's research out there that the more of these injections you get, the more they actually break down the joint long term. And that's why they only like doing, only a certain amount before they just won't do it anymore. And I've had patients say, well, the docs have been like, we're just doing these injections until you need the surgery. So it's staving off what they feel is the inevitable. And again, at the end of the day, steroid injections are not regenerative. So it's not going to get better. You're just getting through the pain. So I think that's a mindset shift that those that are not, well-versed in prolotherapy need to make. And I think some docs are getting it.
And they'll get worse. It's actually creating more ligamentous laxity and more degeneration of that joint and more just structural breakdown of it.
Exactly. So now we've got our patient, we've done our intake, done our consultation, did our PE physical exam. And it's like, you know what, you're a great candidate for prolotherapy. I want you to come back this date, blah, blah, blah. Now they're here, we take them in. And so I don't want this to become, because again, you teach this. And so I think a lot of the points I would love to ask you are not so much for this forum, but I would like to talk about it from 2 perspectives. This is a what to expect portion of it. As a patient, you're on the table, what to expect. And then for the docs who may be tuning in, a little bit about, hey, we talk about ultrasound and imaging and all of that, just a little bit of kind of some tidbits on that as well. I hope that question kind of, I want to look at it from both perspectives.
So the experience itself, I'm fast. So I go fast. I was taught by Rick Marinelli to go fast and not, it's kind of like when you're doing strength training, you have to be concerted and efficient, right? You're not like speeding through the thing. And we want to do that because the nervous system only has a short window, and we want to get it done while that nervous system is still functional before they kind of dump out on your table. So I try to go as efficiently as I can with as much good, solid intention and clarity. And I get it done. Like I can get a shoulder done comprehensively with a lot of injections, because as prolotherapists, we're injecting all of the structures in the shoulder, all of those soft tissue attachments, along with intra-articular. That might be 20 different injections. I'm fast, and I'm fast with a needle so that it doesn't hurt that bad. And often I may be able to have time to get to a second joint. And so it's usually that part's simple. I don't do a lot of pre-numbing because I'm so good with the needle that I think that it hurts less than actually pre-numbing with lidocaine. Lidocaine can be really stingy. So I don't think it should hurt. I don't think it should be a super traumatizing experience. If it is, you either have a terrible joint or you have a practitioner who maybe needs to work on their skill set, because I've heard a lot of patients come back and say, oh, I saw Dr. So-and-so, it was so painful. And what you just did to me, I didn't even feel. I thought, a lot of times they'll say, oh, wait, you're done? I thought you were just numbing me. I'm like, oh no, I'm done. We're good. And so I think that having a light touch and being skilled at your craft is important as the practitioner and as the patient. Just knowing the first treatment's probably going to hurt the most, and then it's going to calm down from there. You're looking at, I usually tell patients once a month for 4 to 6 rounds. Usually I jump to something stronger by then, but that's traditional prolotherapy, and a lot of people go that route. And the second and third and fourth injections will just get easier and easier and easier as those tissues calm down. The first initial treatment, those tissues are screaming quite a bit, I think, in most people, especially if it's an old injury. It's like, get out, those shoulders that are 30 years old, and the guys saying like they're blue collar and they're like, it's not so bad. And you get in there and they're crying. And I'm still being light and gentle, but I know that tissue is old and there's a lot of emotions trapped in joints. So that's it. It's pretty fast and simple. We want to make sure that we decrease the risk of infection, but there's really not a lot as long as that your practitioner is skilled in staying away from the landmines, the big nerves, arteries, and veins. It's usually a very easy, safe, efficient procedure for most patients, I think. Did that answer your question?
Yeah, it does. It does. Okay. And then the second part to it is you touched on it earlier, was the conversation about imaging.
Ultrasound. So I do think ultrasound has its place. Specifically if you're injecting more expensive solutions. So I counsel my docs, if you're doing PRP plus, meaning anything else beyond PRP, there's my little coyote dog, she's taking a nap. I tell them ultrasound is really warranted because that's the standard of care. And it's important to keep up with that. And that's what patients are expecting, especially if they're spending if something that costs $1,000 is in that syringe, we better know it's in the joint. But as importantly, as I've described earlier, we need to palpation wise find all of those ligament and tendon endpoints that hurt. And so that doesn't require as much of the ultrasound. Some will say it does. I don't think so. I use both. Ultrasound is a big learning curve. It took me a long time to learn it. It takes everyone a long time to learn it. It's expensive. It's an expensive endeavor as a practitioner. It's very satisfying when you get good at it, but I certainly do not rely solely on my ultrasound probe. I do a nice combo of both.
Okay, which is awesome. And I've been very lucky because the doctors who trained me, and I'm sure you're familiar with Dr. Vance Inouye, he was like, hey, I'm teaching you how to do this with palpation because this is going to make you a better injector. And he'll use ultrasound just like yourself, certain injections, certain people. For me, I found that my larger patients, if they're very large, I'm using ultrasound because it just makes it more difficult to hit those landmarks, and you don't want to be stabbing around and not getting to the enthesis as well. So that's very important as well. So you mentioned something which led into the next question, which transitions us from during the injection to after the injection. For most people, and I know this is different for everyone, how many injections should they expect over a series?
If we're talking straight prolotherapy with dextrose, like I said, 4 to 6 rounds. Usually I always try to start patients with prolo at least the first time. Because like I said, that first venture into that joint is painful. because those tissues are often screaming. And so I like to use dextrose because it calms and soothes the joints, and it gets the stem cells ready, and it just gets the patient familiar with you and the procedure. And everybody is it's much less PTSD invoking than coming at them fast with PRP. Then I jump them up to PRP when warranted, depends on the region, depends on the patient, depends on the severity, all those things, right? Lots of variables. But if they've got good PRP, meaning they're healthy and they've got good blood, I'm happy to use it. And we'll jump to PRP to be more effective and efficient if we need to, depends on if they're an athlete or whatever. And that, I tell them they're in for about 2 to 3 rounds. So if I haven't gotten them 90% improvement in a lot of factors, and I'll tell you what those are, so the patients can hear this too, and the doctors, I am least concerned about pain. Pain is the #1 reason patients come to see us. But what I'm far more interested in is arresting the degenerative process. I want to arrest and abate it. I want to slow that down. I want to change the microchemistry in there, or the microenvironment, meaning it's in a pro-inflammatory, pissed off state. I'm trying to get it into a healing, calm, soothing state. So like applying that salve. I want functionality improved. I want stability improved. And so what patients will say is, I'm going up and down the stairs better. I feel stable when I stand up from a seated position. I don't have to brace myself and take a moment anymore. I'm able to sleep without pain. I'm able to enjoy sex without pain. All of those things matter. They still might have some popping and clunking, and they still might experience some pain, but maybe they're not taking 800 milligrams of ibuprofen every day anymore, right? And so we're looking for improvement in activities of daily living, but also functionality and stability and abatement of the degenerative process. And then we can work on pain, but pain resolution comes later. And I hope that's helpful for you to hear and for everyone else to hear, because sometimes patients will come in and say, well, I still have some pain, and they think they failed care. I'm like, no, look at all these other improvements we have. Pain resolution will come, right? That's a whole different thing.
Right.
So.
Exactly. And it's a great segue, because now we're in the injection portion. And the first question I want to ask about that is, especially with patients who are active, are athletes or athletic types, they want this injection and they want to get back to the gym that day, next day. They're like, hey, I'm ready. So what's a good rule of thumb for taking time off after an injection?
Oh, this is hard because I'm like them.
Yeah.
Here's what I have played with. I'll tell you what I played with. The rule of thumb is, and what I was taught and what I preach is 2 weeks off hardcore. You can do mild movement. So you could do like recumbent bike set at 0. You can do gentle walks. But when you tell people that, that's variable. Like that gentle walk might be 12 miles for them. Who knows? Like,
Right.
people are.
Yeah.
And then the 3rd week, I tell them to start easing back into what they're doing, or what their normal easing back in. And again, people, they might go straight out and run a half marathon as their version of easing in. So easing back into their main activity. Here's what I have done personally, because I'd be crippled without, I've had every joint injected. Like I live off Prolo. I don't know how people who don't have Prolo like get along. I inject dextrose as often as I need to, and I train through it. I just straight up train through it. I'll take 5 to 7 days off only because that joint won't grab and engage the way that I'm used to. So like say the hip, if I inject my hip, my glutes will not engage when I go to squat or lunge. I just can't get that stability that I'm used to. So that it impairs that for a little while. So I tell them, be cognizant, you don't hurt yourself. But for my athletes, I tell them a good 5 to 7 days for safety reasons. And there's other reasons for it too. And then I tell them to go back to activity gently and see how they feel, because it depends on how much money they want to spend, Greg. If they got the money to spend, I will get them through it with dextrose Prolo. And then when that isn't enough, then I jump them. So for me, for my hip right now, the first hip I treated, I went straight to PRP. I gave myself a frozen hip. It took me 10 months to reverse that with dextrose therapy, which was a total nightmare. This other hip started, and because I'm like the middle-aged hip lady, I do dextrose 5, 10, 15, 20% regularly, pretty regularly, honestly. And then I am now ready for PRP and something else. I'm going to add some, biologics to it. It'll be awesome. But I think that that's going to be a better route. And that's what I've done for a lot of my active athlete patients. So I don't know if that helps, but I just tell them like, all bets are off. If you go back to activity, you might totally blow this up. You won't be worse off, but we might like ruin all the good effect of healing. Right. But let's see what you can do, because I think you're right. Like, especially professional athletes, they don't have time. Like they got to get in and get through. They might just need more therapies.
Right. And what I've been able to do, and I've been that person, because like you, maybe not as many. I've done lots of prolo and I've played around like, oh, got some prolo here. Let's inject my knee, see how this feels. And, you know, and I've been the person to say, oh, I got injected at 8 a.m. and 7 p.m. I'm in the gym because I feel great, you know, and I've also been in certain injuries I've had where it's like, okay, I need this full 2 weeks because I am struggling and I want this to be as effective as possible. Right. And that's super duper important as well.
Yeah.
Now in general, is there a, you know, post-injection do's and don'ts that you like to share with your patients or the doctors that
Sure.
you're training?
I personally tell them to stay out of bodies of water for 24 hours at least, more like 48. Like, don't go in hot tubs or lakes or ponds, because I just put a route, you know, from your skin to your joint, and I don't want anything traveling up that route. I tell them to expect some pain. I have no idea what that's going to be at all. And I tell them that. I never know. I mean, I've had 10% dextrose injected into me and I hurt like you gave me PRP. And I've had PRP and it hurt like I was going to die. And I've had PRP other times. It was no big deal. So I just tell them, I have no idea how you're going to respond, but know that it probably will last 24, maybe 48 hours. And then it's just going to go away as fast as it came on. Usually for them, it's not like a long residual thing. If it is, we got to check some systemic stuff. Like, we got to look at your whole being, because that's not normal. It's not bad. It's just not the norm. And I tell them to use it. I am not a bracer. I know that a lot of these regenerative clinics have big businesses selling braces, but to me, it's a big business. And I am certainly not trying to brace anybody. I don't know if you do, but I am a big fan of movement. And so I tell them to chill on it for about 24 hours. And then, but you know, that first 24 hours, you can stiffen up so bad you can't get out of it. So with shoulders, like, I want them in the hot shower, wall walking, moving their shoulder through space almost immediately so that it doesn't lock up on them. I'm a big fan of like keeping the gunk out and keeping stuff mobile and juicy, and, you know, just not overdoing it. And again, people are going to do what they're going to do, but that's on them. So that's what I tell them post.
Okay.
What am I missing?
Let's see. How about, things, let's go naturopathic on them as well. Any supplements to avoid or to take while they're in the healing phase post injection?
I have found that taking supplements or discontinuing, you know, some of these herbs we give that are so potent and powerful are also COX-2 inhibitors. I haven't found them to be terribly detrimental. So I used to take people off and then tell them to wait a while and then put it back on, because we don't want to inhibit the healing response or the inflammatory response with any COX-2 inhibition. But truthfully, like fish oil, curcumin, white willow bark, like, I say go for it, because I've had so much Prolo on myself, or given myself so much Prolo, that there's times when I just need a little dose of white willow and curcumin just to snap out of that really bad post-injection pain. And then I'm good. And so again, I tell them, like, don't go crazy on it, but you can use those as needed. Definitely no for over-the-counter NSAIDs. So no ibuprofen, no Motrin, none of that for a good 10 to 14 days prior or after. That can be hard for people who are addicted to it and need it for pain resolution. And so we wean them down before the procedure, and then we give them the procedure. And then you know, in that process, they've shifted onto those nutraceuticals and those herbs. And so I just tell them to continue. And that's really it. Like, I make sure that they're eating well prior, because, so, you know, you can't make collagen unless you eat collagen. That's a conversation to have with vegans and vegetarians. You know, they got to know, like, I don't get as good a results out of them when I treat them. But that doesn't mean maybe we can compromise and put them on some kind of supplemental collagen and not necessarily dietary. So yeah, just kind of, that's what I do.
Great. And then we talked about it a little bit earlier about the post-therapy, physical therapy, and, you know, getting that remodeling process fast and linear. And I think that's and that was the analogy that I was going to say earlier, is that when I have that person who's like, oh, doc, I got to get back in the gym, man. I got a game in 2 weeks, or I've got, you know, especially the bodybuilder types, they just want to get back to lifting right away. And it's like, okay, what we just did, imagine that as fixing a bridge, tightening the spans on a bridge. And you're saying you want to open that bridge up and let cars go on it while it's under reconstruction. So think about that.
Yeah.
Oh, okay. So 3 days off. I'm like, okay, dude, I can't. you know, so
just say, how much you want to spend. That's what I tell them. I'm like, it's up to you how much you want to spend. You're not going to, we're still going to have some improvement. How much improvement? I really don't know. I don't know if you follow my instructions perfectly. I don't know if you there's no absolutes in this. So I've seen thousands of patients, and no one ever heals the same. No one ever has the same experience. No one has the same experience on different joints. Like they may fly through their shoulders and then you do your knees and it's like a whole different world. So I just tell them like, you know, it's up to you. This is what I know to be true. And you really do need to, I'm talking more to like the postmenopausal middle-aged women who have no shoulder musculature at all and have never lifted a weight in their life. And now they have chronic frozen shoulder. And I've done all this work to get their shoulder back to movement, and they don't want to go to a PT. They want to turn around and blame me that the therapy didn't work. And I'm like, no, lady, you got no muscle. If you got no muscle, you got no shelves. I mean, I know mine are little, but they're strong as heck. And they didn't used to be that way. They used to be wobbly little, you know, joints. And so it's super important to follow up with some kind of strength and conditioning rehabilitative process, in my opinion. Like that's not negotiable.
Okay. So that's part of the plan. Like, hey, I'm treating you, but you're going to do some type of PT rehab work because, you know, and I think that goes back to treating the root cause as naturopaths. It's like, hey, this injury outside of like, hey, I fell off a bike or something like that. If it's overuse, especially, or some movement pattern dysfunction, I can inject you, but if you don't fix that pattern, it's probably coming back.
Yeah.
You know?
And on that note, with those women I just spoke of, I quit injecting them. I actually started sending, not to a PT, I started sending them to strength and conditioning coaches that I trusted, because often they just needed to start lifting. And the minute they started lifting and getting strong, all the pain resolved. They didn't need injections. So I was like, go spend your money on a good coach and come back to me if you need it in 3 months. And almost every single time they're like, I started taking the supplements you suggested. I quit eating sugar. I quit drinking so much damn wine, and I started lifting, and all my shoulder pain's gone. And I'm like, hallelujah. It works.
Oh, that's so amazing. And it's really cool you said that, because that's part of my basic pain diet. It's like sugar, dairy, alcohol. Sorry, man, you know, this is not time for comfort food. This is time for healing food. So whole foods, lots of vegetables, a lot of lean protein. And, you know, you can do the spicing with turmeric, and all the great things can help people heal. And I think that's important, to put yourself in the environment to do that. Getting good sleep. All this, so the basics, drinking water, the basics are all the same when it comes down to it. It's just adhering to it. Now that's a whole different story, you know.
Well, even water, it's crazy how contingent your cartilage is on water. It's a glycoprotein that needs water to be bouncy and slick. I think a lot of people's degenerative joint stuff, when they're like, I'm bone on bone, I'm like, I think you were just dehydrated for 30 years. And when you take that tissue and you don't hydrate it, it gets crunchy and friable and breakable like a dried out sponge. And so I think a lot of people are just eroding their cartilage from dehydration. Truly, I feel very strongly about that.
This conversation going all day, because you just made me think like, oh, I didn't ask you about that. So what about our bone on bone OA patients or osteoarthritis patients? Are they candidates?
Yeah, I'm like, welcome to the club. Like everyone who walks in here is bone on bone. That's like it's like some diagnosis of, people really love their diagnoses. I have found, not everyone, but a lot of people really, and I used to like really hang my hat on that. Well, I have this, I have Hashimoto's, and I have bone on bone. And I'm like, good for you. Welcome to the club. So does everyone else who walks in this clinic. You know, it's not that unique. Often those imaging reports, or those images, those x-rays, are showing osseous bone, and they're showing space decrease, but they're not actually showing the quality of that cartilage. And again, they might just be pissed off joints. And if we can get some dextrose in there as a soothing and priming agent to initially get that regenerative response going, I can get a lot of information from that. And then I know where to go with the bigger guns. But until I get that information, and until they're eating well and drinking water and sleeping and doing all the and exercising, I don't really know. It's like, if they keep pouring lighter fluid on the fire, of course it's going to hurt. And really, I just think these orthopedic diagnoses that people get from x-rays it's just one piece of the puzzle. That doesn't mean that or when people say, I must get hip replacement surgery. And I'm like, I'm looking at under ultrasound and your hip looks awesome. Yeah. Like, just because you fit in an age category and it's that time for you, and your orthopedist, that's the only hammer they have, that doesn't mean you need a hip replacement surgery. You know, if I had been a regular 45-year-old woman, I would have had a bilateral hip replacement by now. I'm still like doing super heavy kettlebell swings and Turkish get-ups, and I have minimal pain in my left hip, and my right hip's completely 100% fine. And that was all just mostly with dextrose. So
Yep. It's simple yet powerful. I think that's
Yeah.
when people come in and I'm talking them through the regenerative injection menu, so to speak. And, everyone wants to, okay, I've heard about these exosomes and I've heard about, PRP and all that stuff. And there's a time and a place for those therapies. But again, at the end of the day, you can work wonders with dextrose. And so I'm very glad that, we're able to share that and talk about that, because I think we kind of forget about this powerful tool in our toolbox. So I
I think
appreciate that.
Yeah, thank you. I think most doctors aren't trained in it. I think most doctors, especially nowadays, and I appreciate you for caring about it, because most doctors that are graduating are like, I'm going to go do the big guns and make money and pay off my loans. And I'm like, you're missing the entire arsenal of naturopathic medicine. That would be like skipping all the nutraceuticals and herbs and going straight to antibiotics, in my opinion. Like going straight to exosomes and stem cells is foolish on so many levels. For me, you know what the big change maker was? Getting off gluten, like my life depended on it, and implementing testosterone therapy. That shifted my pain so monumentally, to the point where I know when I need to redose my testosterone by how much my hips hurt. And getting my thyroid balanced, because the medication I was taking was not right for me anymore. Those are things that take time to fetter out, so like, we buy ourselves that time by giving them pain relief through dextrose therapy, through maybe some PRP, getting them on the path, and then and then they implement the lifestyle changes. That stuff takes time, right? It's a journey. And so I think all of it together, I don't think there is another type of physician as well skilled to do this kind of work as naturopathic doctors. I mean that wholeheartedly, like, especially those of us who can prescribe in the states that we're in, like, we have the full arsenal. It's like the full meal deal.
Oh yeah.
People are lucky to have access to you.
I tell them that all the time. You're
It's
lucky to
true.
have me. So they come in the door. It's like a big sign behind me. You're lucky to be here. You're so
Well,
lucky.
you're kind and you have a good heart, and you genuinely want to help people get better. And I think that is a big shift from a lot of the regenerative clinics I see.
Okay, for sure. Well, I know you got things to do. You got kettlebells to swing and Turkish get-ups to do and all that great stuff. So I want to thank you for the time. Where can people find you? Where can we find you online?
Yeah. I'm mainly on Instagram right now because managing that is a lot. So you can find me at Dr. Tyna. It's DRTYNA. And if you, I would love to have you guys follow me there. Also, check out my website, drtyna.com. Right now, what you can grab there is my free book called Pain Free and Strong. And it's like the 6 pillars that you must master before you head into Dr. Greg Jones's office. Make sure that you've got like all the things we just talked about, making sure that those are settled to live a pain-free and strong life. And that's about it. Oh, and I have a podcast, Pain Free and Strong Radio. So it's painfreestrongradio.com. And I have Paul Anderson did my 101st episode, and I just did my 102nd today. So I've got 102 episodes about all kinds of stuff that would, very much resonates with, I'm sure, what you tell your patients.
Oh, that's awesome.
We should get you on there.
Oh my gosh. I think this is enough Dr. Greg Jones for one lifetime here. They're like, oh my God, this guy again. But no,
Yeah, they'd love it.
That'd be awesome. And
Yeah,
really
let's
cool
do
to
it.
talk about some things. So I'm down for that. So, all right, everyone. I hope you have learned. If you have more questions about prolotherapy, you know where to find me. And I think, Dr. Moore, Dr. Tyna. It's so cool. I get to call you guys by your first name, and Tyna, and it's like, oh, I made it. Y'all can't get mad at me for saying that here. But
oh, you were always polite as a student.
I appreciate that. I appreciate that. And so I want to thank you all for tuning in, and we'll be talking to you soon.